afternoon. I'm Elena Nunley, Program Coordinator for the New Life Now Weight Loss Center at Baptist Hospitals of Southeast Texas. Here in Beaumont, Texas, we have the privilege of having Dr. Alex Ordonez, certified bariatric surgeon, on our surgical team. He provides a level of expertise regarding all gastric surgeries, and having that knowledge has brought about a wonderful, wonderful aspect of continuity and quality of care our patients receive. We did just recently visit with him about the vertical sleeve gastrectomy, but some patients are candidates for the Roux-en-Y gastric bypass, either as their primary procedure or potentially as a revision if they've had some chronic problems. We do welcome you to come have a consult with Dr. Alex Ordonez in his office, and we'll let him tell us about his skill set regarding this Roux-en-Y gastric bypass.
Hello, thank you. Correct. The sleeve, the bypass, and revisions are the most common surgeries that we do nowadays. We talked about the sleeve recently. The Roux-en-Y gastric bypass is actually the oldest, I would say, operation that is still done right now. There's a few other weight loss surgeries that are no longer done because of issues or complications. But the bypass, I always tell my patients that it's the most commonly done surgery when it comes to weight loss procedures. It's been done. It was started as a procedure for weight loss in around 50 years ago. It's been done laparoscopically for since 1980. It's still the gold standard of the bariatric procedures because it's about the best in terms of weight loss. We talked about the sleeve before. The sleeve is a really good operation. It's become really popular because when you compare both, the sleeve has a little lower chances of having issues or complications. But that doesn't mean that the bypass has a lot of complications. It's a little higher potential situations, but is not significantly different. I still think that there's some indications, some instances where you think about a bypass. Most of the time, you think about a bypass when you have a patient with a really high BMI, usually when the BMI is higher than 50. And along with the high BMI, you also have somebody who has diabetes, who requires multiple medications, including injections with insulin, oral medications, and still have a poor control of diabetes. So at the same time, most of these patients have high blood pressure, high cholesterol, and also acid reflux, or what we also call GERD. So when you have a patient who has this combination of what we call medical comorbidities, when you want to present the option to the patient, it doesn't necessarily mean that you're going to do it, because ultimately what we do as surgeons, we give the patient the options. We have to make sure they understand the risks and benefits, and then ultimately they choose what they feel comfortable with. I have to mention GERD, acid reflux, heartburn, is a special situation because that's one of the few things that when you have a patient who's thinking about doing a sleeve, you have to be careful. It doesn't mean that you can't do one, but depending on how severe the reflux is, you want to let the patient know that the sleeve is maybe not the best option. And this is when you think about probably bypass, because this is about the best solution that you have for a severe acid reflux in a patient who needs weight loss surgery. There's also something called Barrett's esophagus. Barrett's esophagus it's a consequence of having severe acid reflux during many years, and that's one of the only cases I would say of situations where I don't recommend doing a sleeve. So severe acid reflux, GERD, and Barrett's esophagus, sleeve is not a good idea. Bypass is probably the best way to go. When it comes to the bypass, it's also done laparoscopically. Again, we don't have to make big incisions anymore for these operations. Takes anywhere from an hour and a half to a couple of hours. It's a little more complex from the technical point of view compared to the sleeve. When you do a sleeve, you just trim the stomach when you do a bypass, you have to do a few things. Number one, we create what we call a little pouch. This pouch is about 2 inches long, and it's about 30 mLs in capacity. 30 mLs is about 2 tablespoons, more or less. Once you create a little tiny pouch, which is going to be what we call the new stomach, then you have to work on the intestine. So what we do is we go to the beginning of the intestine, we count about a couple of feet downstream, and then we cut the intestine right there, and then we have to start rerouting the intestine. So we're going to reroute it all the way up here and create a couple of new connections. One new connection between the intestine and the stomach, and another one between the small intestine because we have to establish continuity. And that's the difference between the sleeve and a bypass. Both are going to make with both surgeries, the patient are going to be eating less. With both operations, the patient is going to feel full quicker than before. With both surgeries, the patients are going to have less appetite because both affect the appetite cells. But the difference with the bypass is that there's not going to be a good absorption of some nutrients. It's mainly the carbohydrates and fats from the diet. So that's an extra way of losing, of not taking in calories, and that's an extra way of losing weight. Complications wise, most patients do well. About 95 to 98% of patients don't have any problems, which I think is pretty good. About 2 to 5% of patients can develop problems. Most of the time, if there's a problem, is because some patients they forget to follow the nutrition plan. And sometimes smoking or taking medications that they are not supposed to take is when you see issues with the bypass. Other than that, again, most of the time they don't have any complications. This is also a good option and basically the best option in patients who have had surgery before, especially sleeve. There's a good number of patients I've seen that come from that they've had surgery somewhere else, and GERD is a common presentation, weight regain, and some of them you can consider a bypass as a solution for the problem, either because they have severe acid reflux or because they've had inadequate weight loss or weight regain. I have no problem seeing patients that have had surgery in any other place. I have training to perform any of these operations, including redo surgeries, what we call revisions. And I'm happy to discuss with any patient about any potential situation that has happened because of another surgery.
Excellent. The level of knowledge and skill that Dr. Alex Ordonez brings to Beaumont, Texas has been wonderful for our patients. We understand that it is just a tool, and through lifestyle change and ongoing work with your diet and your exercise plan, you'll continue to see a new and healthier you. Thank you so much.